The next panel is the psychosocial disability, the world we want in our madness. And it's going to be moderated by Action Amos. And let's see. Action has a master's degree in child and adolescent mental health. And he's also got an MBA in leadership and sustainability. He's got a postgraduate diploma and a bachelor's in development studies. He's a member of the WHO mental health expert group, and he will be moderating this session. So over to you, Action. Are you there?
Thank you so much for that introduction, and welcome to this session where we'll be talking about the world we want in our madness. Before I introduce the panel that will be part of this discussion, I wanted just to ask all of us present here. It's an interesting conference where we're talking about joy and how to find it in the health sector and in other social spheres of life. So I wanted just to ask a question, and by show of hands, how many of you have been in a workshop with people that you would maybe classify as mad people? Maybe by the show of our digital hands. Okay, I can see one. Okay, two. Okay, three. Okay, all right, okay. All right, maybe if the question was asked in the other way, we could have asked it in a different way and say, how many of us would classify ourselves as mad people and are present in this workshop? Maybe the numbers could have been more. Okay, maybe they could have been less. Well, welcome to this session, and I'm glad to be here. As has already been mentioned and introduced, we're talking about the world we want in our madness. You know, there are three things that the Sustainable Development Goals, I would say, actually, if you were to sum them, you would sum and say these are the three things that are much more focused towards. One is to stop people from being poor, stop people from being hungry, and make sure that everyone has good health care and education, and make sure everyone is treated fairly. So if you look at those 17 goals, you find that all of them, they're talking to these three things. And if we are to achieve this, we'll all say we are happy. So this is what we're going to discuss. I'm glad as part of this conference, we've been talking about, the joy and other things, the ethical issues, the exclusion, the inclusion, discrimination, and stigma as things that actually deprive people of the joy that they want. I have three panelists. I noted one of them is yet to join, but I know you will be joining as we continue. On the panel, we have Robina Nakanwagi Alambuya, who is a renowned mental health activist and assistant disability inclusive advocate and feminist leader. She's the executive council member of the African Disability Forum and also a board member of the Pan-African Network for Persons with Psychosocial Disabilities and also World Network of Users and Survivors of Psychiatry. And she's a founding executive director of Triumph Uganda Mental Health Support Recovery Program. Welcome, Robina.
Thank you so much.
Thank you. And secondly, we have Dr. Tafadzwa Rugo, who is with the Pan-African Network of Persons with Psychosocial Disabilities as a mental health technical advisor. He has over 25 publications on disability and some journals, books, chapters, and has edited a book teaching adolescents with disabilities, sexual and reproductive health. Today, he will also be sharing his experiences on the world we want in our madness. Welcome, Dr. Tafadzwa.
Thank you very much. Thank you very much, Amos. Good afternoon, everyone, and good morning to others in other parts of the world.
Okay, thank you. We'll be joined by Mr. Sylvester Katontoka, who notified me that he'll be, he had some challenges logging in, but he will be logging in. Mr. Sylvester Katontoka is the president of the Pan-African Network for Persons with Psychosocial Disabilities. He was diagnosed with depression in 1996. 2 years later, he formed the Mental Health Users Network of Zambia and became involved in championing the promotion and protecting for the rights of persons with psychosocial disabilities. Since then, he devoted his efforts in activism, fighting stigma and discrimination, and is involved in the field of mental health. And he will be part of this. And currently, he's part of the teaching faculty at the Indian Law Society in Pune in India. So he'll be joining us, and he'll be joining the conversation as we move on. So to kickstart our discussion, maybe I'll ask Robina. This conference is about joy. Can you just tell us, you as a mother, as a wife, as a person with a psychosocial disabilities, what has been your experience when it comes to these issues? Yes, Robina.
Okay, thank you so much. Thank my fellow panelists that are with the joy in healthcare, finding joy in healthcare in Africa. This is a great opportunity for us to be together and discuss issues of life, because it's all about life and human beings. Yeah, I'm going to be, you'll allow me just to take off my video as I present, just to strengthen my network. Thank you. Yeah, so as Amos, you have said, we are tackling the issue of the world we want to see. First of all, as human beings and as people who may appear or different from others, persons with disabilities, in this case, persons with psychosocial disabilities. We are living in a world where we have a diverse population of people. So it is very good for us to discuss what do this particular population, what are the challenges they are finding, and what is their heart, what would they want to see, and what prevents them, what are those barriers. So because we have a very limited time, I will just go straight to a few things, just speak from the heart, like a person, like among the lay people who receive the health services. So as a caregiver, first of all, and then as a person, mostly using the mental health services and other health services. So what are some of the barriers maybe that we face before I can say what we really want? Some of the barriers that are all challenges that can prevent us to enjoy joy while getting the health services here in Africa is lack of awareness, the limited knowledge that the population has about the diverse people in the society and the specific needs. So for us, persons with mental health issues and also psychosocial disabilities, this one, most people do not understand. They have very limited knowledge, so they live with myths and misconceptions. And this has brought a lot of stigma and discrimination. The labels, which are using oppressive language while discussing us, is another issue that disables even the more and brings more exclusion. you know. Then we have the unwillingness of people or service providers or other stakeholders, be it family people, the unwillingness to unlearn what people have learned or have grown seeing or hearing. They continue with it even when giving services. People are not willing to unlearn. I really remember one person wrote and said that the illiterate of the 20th century will not be those who don't know how to read or write, but those who are not willing to unlearn, learn, and relearn new ways, new approaches, will remain illiterate in the century that we are in. So another issue is that you know, when we are living in society and certain groups are structurally excluded or marginalized, like girls and women, this is also another challenge. And other groups that go among, like Amos has said about the Sustainable Development Goals. It's very clear that it talks about making sure if we are to develop together, then the marginalized groups that are structurally excluded should be not left behind. Otherwise, we will not develop together. So what is the world, knowing that we have those just identified big challenges, what is the world we want as it is in our madness? Because we've said that the labels, like Amos said, one of the labels that is given to us, that those people are mad. So what can they do? But okay, if you really look at me or us, that we are mad. So what is the world we want in our madness? I may be like that, but what do I want? Because I'm a human being, I have a right to choice. So what is that I want? One of the things that I really felt as human beings that the world would like to see in the years, in ahead, in the future, beginning today as we listen to one another, is a world, a society where I live safely, where we are safe in a loving and an enabling environment. You know, love is something very big which we cannot discuss here, but you know, love is supreme because it brings out many things. That love will always believe the best. Love never fails. It never gives up people. You know, love is patient, it is kind. So we want that safe, loving, enabling environment. Then we also, according to the Convention on the Rights of People with Disabilities, we want a world where people practice reasonable accommodation. When we appreciate the different diverse, you know, that we are a diverse population, I will not be forced to be like the other one. I will just be accepted the way I am. And then the society has to adjust certain things to live with me. That's what we call reasonable accommodation, and it's a standard of the Convention on the Rights of Persons with Disabilities. We want to live in a world where we live as human beings, together with, on equal basis with others, where we are listened to non-judgmentally. When I'm speaking, I should not be judged. Instead, I should be listened to in a very respectful way. Because as I speak in my own way, like some people say, okay, she's mad or he's mad, he's speaking like this. But when you listen and you are not judging, the things I speak, you know, to me, they are making sense, and you also find sense. And you may find that those things are also speaking to what is happening in my body or happening to me and around the society. Then we also would like to, the universal design, as the CRPD standard is, if things are made, we would like them to be on equal, we would like things to be made so that everyone else is able to fit in and to use that, not only a few others. We want equal treatment, to be treated on equal basis with others, and not leaving the gender equality. Then we talked about the labels, the stigma. We would like a world where everyone will determine to stop stigma and discrimination, where we can live free of exclusion, where we are able to get involved and participate on equal basis with others. Because of time, I may have to stop by ending to say that
thank you.
We need space to be, I need space to be myself. That's how I can end the world. Thank you so much for giving us a
Thank you,
voice.
Robina, for that insight. And let me move on to Dr. Tafadzwa, maybe in just a minute or two. What has been your experience, both as a disability practitioner, as a researcher, along the vision of persons with psychosocial disabilities? Dr. Tafadzwa.
Well, thank you very much, Amos. I think it's a quite a big task to just compress everything that happens within the field of disability in 2 minutes. But however, I'll try to do that. I think first of all, we need to look at the history, the historical movement of people with disabilities the world over. And we also need to acknowledge that when we are talking of people with social psycho disabilities, they are part of the 1 billion people who were identified by the World Bank and the World Health Organization as people who constitute the majority of people who are marginalized the world over. So the challenge that we have been having over the past probably years or decades in terms of the disability movement is that we have been treated as a homogeneous group. Always when they talk of people with disabilities, they just assume that it's a homogeneous group, but they don't really understand or investigate the different diversity that is among us people with the disabilities. So that approach, when it comes to people with social psycho disabilities and other minority disabilities, it has got a challenge. The major challenge is that they're overshadowed by other disabilities. So when people are talking of policies, programs, activities for people with disabilities, usually what comes to their mind, these are people with physical disabilities, people with impairments, and other visible disabilities. So those with social psycho disabilities, which is sometimes invisible, they are then neglected. So you will see that then in most countries, people with social psycho disabilities, they are hardly recognized at law, at the police level. You hardly find them being included in police. Why? Because it goes back to the disability management that Robina earlier on talked about. That mostly disability, it was being taken from a medical perspective. So obvious when it is being taken from a medical perspective and someone has got social psycho disabilities, that person is not given any audience. No one listens to them because already the management is already categorized them as mad people. This is why you see in most parts of the world, institutions for people with social psycho disabilities, they actually all the increase instead of all the decrease. We will still see quite a number of people with social disabilities going to institutions or maybe which are related to hospitals, rehabilitation, etc. Why? Because what we think is maybe probably the medical personnel are the people who are very good at dealing with the people with social psycho disabilities. So that has been the major approach even in Africa. So even within people with social psycho disabilities, they ought not to be categorized as a homogeneous group because we've got different categories of people. There are some people with mild psychosocial disabilities, etc. So you can't then treat them as a homogeneous group. So that has been the challenge. Then basically when we look at when you look at international treaties in the UNCRPD.
Okay, let's come back to the treaties in a moment. I see, right. Yeah, sure. I'll give you an opportunity to talk about the treaties and legal instruments. Mr. Sylvester, just your experience as a person with a psychosocial disability, maybe just exactly in 2 minutes.
Experience as a person with a psychosocial disability. When I look into Africa, we see two Africans. Us with psychosocial disability being a group on our own compared to the rest. If then we can have such an Africa, which are having, we Africans, Black Africans, having two people. Is that a pain? Oh yes, it is. And you find that this division, creating two people in one Africa, is based on ignorance from another group who thinks that we are not a people. Why are they thinking that we are not a people? Because we have journeyed the mental health system. The mental health system that has never helped us at all. The mental health system that has reduced us to non-entities. The mental health system that has never wanted to actually come closer to us. These systems in the now in Africa need to be done away with. We're so thankful that right now we have the convention that is bringing the human rights perspective. On this one, human rights perspective, on this one, I think as persons with a psychosocial disability gonna be stubborn, wanting to make people identify us as a people, not as a subject of treatment, no, but as people that hold rights, work, housing, all just but these basic things we are entitled. But any system that denies us these just basic things, that should be of the past, not in this new generation.
Thank you, Mr. Katontoka, for those sentiments. Looking at our time, we just have under 7 minutes to wrap up. With that vision in mind and the challenges you have mentioned, I'll start with Tafadzwa, maybe as a researcher. What do you then envisage should be the support that is required, you know, maybe from the research perspective, from scholars, just in a minute, Tafadzwa? What do you think, yeah, how inclusive can we be?
Okay, I think from a policy perspective, first of all, we need to move away from this tokenism approach and adopt the human rights perspective, where we make sure that people with social psycho disabilities, they become participants in the development in issues that they affect themselves. And what we need also to do is to see more people with social psycho disabilities participating in various researches so that they can inform policy, both in and academic. This is what we really need. And they also need to be capacitated to occupy certain influential positions within organizations, within government. So if we manage to do that, we are now inclusive. Thank you.
Thank you, Tafadzwa. And Robina, moving forward, what do you, what kind of support, you know, would you think will make the world that you were talking about? Yeah, just in a minute, and also talk to the scholars that are here, talk to the development workers and social workers, you know, medical humanities specialists that are here. What kind of support?
Okay, thank you so much. I think for anyone who is willing to change or to unlearn, as I said, that it is very important that you embrace the UN Convention on the Rights of Persons with Disabilities. We always call that is like the Bible to follow while you want to do the right things for persons with disabilities. And this joined together with the Sustainable Development Goals, then I think we will be able to get what we want. Thank you.
Thank you. And Mr. Sylvester, your last word, just in a minute or so.
Just some space. Anyone who's going to talk about our lives, can they give us a leeway to tell them what are challenges in our lives? I think we are a better people to speak about our stories. Can they just for once listen to us? Thou shalt not be prejudiced, that shall not just push us. Be part will actually help in shaping the direction of the mental health sector, not only in Africa, but global. I know some colleagues out there away from Africa, they have been able. Why should we fail? Why should we fail? I don't believe that we are a people that will be failing. Just give us some space, we'll prove you wrong. Few lamentations. I submit.
Thank you for that submission. I appreciate Mr. Katuntoka. Well, colleagues, I think that actually pushes us to near our time, and I think there was a clear message. Dr. Famini, Dr. Chisomo, researchers, scholars, anthropologists that are here. Well, we need to be inclusive in all that we do. But maybe for just under 3 minutes that we're left with, maybe any questions or comments before I hand over to Nolazi.
Please take the full 3 minutes. This has been so exciting, such a passionate group.
Oh, thank you. Thank you. So any questions? Okay, I am not seeing any questions or any comments. So we want to thank you so much. Okay, I see from Carla. Maybe you have something to say.
Thank you. I was struggling to find my little hand up mode. Thank you very much to everybody for your input. The questions I have, and I think it's been very central, is this idea of listening and who tells stories. And this has come up a lot over the last 2 days about who gets to speak and who gets to tell the stories of people's lives and how. So it's not really a question, just a thank you to participants for reminding us that whether it's policy or whether it's provision or whether it's research or whether it's activism, that central question of listening and hearing is important. So thank you for reminding us to hold ourselves and others accountable for that. Thank you.
Thank you for that compliment and comment, and we want to thank you all, for inviting us to be a part of this discussion conference. It has been helpful in quite some lot of ways, and we're looking forward to further engagement and working with you all. Thank you. Bye-bye.
Thank you very much,
Thank you.
Action.
Bye-bye.
And thank you very much. It's a very powerful panel, as already Chisomo has commented. The next session is Katrina, and it's a mindfulness and meditation, and it constitutes our health break. And so over to you, Katrina.
Thank you, Nolwazi. Thank you. I've been really pleased that I've chosen the meditation for this session that I have, because throughout the last 2 days, we've been speaking about joy, and is joy something that happens in the absence of sadness, or what is the relationship between joy and emotions and feelings that are negative. And this meditation is going to guide us through the 8 pillars of joy, and we're going to work through those 8 pillars while holding on to a problem that we as individuals are experiencing. So I'm going to guide you through this, and I want to be able to have the full 15 minutes. So I'm going to ask you to start by sitting comfortably in your seats. I suggest you uncross your legs and just place your feet firmly on the ground. And you can place your hands comfortably in your lap or on your legs. And if you would like to close your eyes, you can do so, or just allow your gaze to fall softly in front of you. And let's begin the meditation by taking several long breaths in through your nose and exhaling out through your nose. And as you take these full, mindful breaths in, you can just observe how your body begins to relax a little bit. And you can perhaps invite a small smile onto your face, allowing the muscles around your jaw to relax. Allow your breath now to be steady, to take its own rhythm. As I said yesterday, you can experience your breath as if it was a wave, and you're surfing that wave. And I want you to call to mind a problem or a difficulty that you are dealing with right now in your life. It can be big or small. I encourage you to trust whatever first comes to mind. And I want you to just reflect on this situation, this person, this challenge that you're dealing with. You can almost imagine describing this situation for yourself. And the first pillar of cultivating joy is giving yourself perspective. So I want you now to try to step back from your problem or your situation. Give it some space. And see yourself and your problem in the context of a film or a movie about your life. Now you can imagine thinking about the problem that you're experiencing right now from the perspective of the future, from 5 or 10 years from now. And from this perspective, try to recognize that your problem will pass. I'm now going to invite you to practice some humility. See yourself as one of the nearly 8 billion people, 8 billion human beings on this planet. And see your problem as part of the pain and the suffering and the difficulties that so many human beings experience. see how deeply connected we all are to one another. And see how also this connection you have to others makes you stronger and more capable of dealing with the problem that you're experiencing. The third pillar of joy is humor. So smile and see if you can have a chuckle at your problem, at your shortcomings, at your human frailties. And just try to find some humor in this situation and in your struggle. This ability to laugh allows us to accept life as it is, even as we continue to strive for a better life for ourselves and a better world. And as you find humor, try also to allow that humor to manifest on your face as a small smile. I invite you now to work with acceptance. See if you can find some acceptance in your struggle. Accept yourself for having very human limitations. And remind yourself that painful realities do happen. Painful realities happen to ourselves, to those we love, and in the world at large. I invite you now to place a hand on your heart as we cultivate forgiveness. I want you to try to find forgiveness for yourself, for any part that you have played in creating the problem that you're experiencing. Try to connect with the softness that comes with forgiveness. And give yourself permission to be forgiven, to be soft with yourself. And we're rarely in these situations alone. So I also invite you to try to find forgiveness for anybody else who might be in this situation, in this problem with you. Try to find forgiveness for them and for their limitations. Allow your hand to return to your lap or to your legs. And consider whether just possibly you can find things in this situation that you're in to be grateful for. Can you be grateful to people who might be standing with you as you face this challenge? Are there people who are supporting you? Are there ways in which perhaps this thing that you're experiencing right now as a problem will ultimately contribute to your growth as a human being? You can return your hand to your heart again as you cultivate some compassion for yourself. Compassion really belongs in your chest area. So with your hand on your heart, remind yourself that you are not meant to be perfect. None of us are perfect. Have some compassion for yourself and how you're struggling with this problem. And now send that compassion from your heart out to your loved ones, to those you are struggling with, and to all those who are in need of love and compassion right now. And finally, I want you to consider generosity. I want you to consider all that deep generosity, feel that deep generosity in your heart. Be in connection with your ability to be generous with yourself and to be generous with others. Imagine yourself radiating that generosity out to all those around you. And I want you to take one final big full breath in. Feel your chest, your heart, your belly expand with your inhale. You can raise your hands up with your inhale. Move your spine a little bit, wiggle your hips. Rain your fingers down as your hands return to your lap. And when you're ready, slowly open your eyes and join us back on screen. If you enjoyed the meditations that I've been leading you through over the last 2 days, I've taken and adapted them from the book called The Book of Joy, which is created in collaboration between the Dalai Lama and Archbishop Desmond Tutu, and there's a lot of wisdom there. Yeah, so thank you for allowing me to pass that on to you all. I will hand back to Chisomo. And yes, thank you, Amir, for posting the link to the book in the chat for those who are interested.
Wonderful. Thank you so much. I think that was really important. I think, especially with the beautiful intensity of the last couple of posts, to kind of rebalance ourselves and keep going. So we're about halfway through this session and coming close to the end. And we're going to pass along to Victoria, but I just want to introduce a minor adjustment. Victoria, if that's okay. Benson has now been able to connect, and we would like to add his presentation to the group, and we'll just extend by 10 minutes. So we'll just ask everybody to keep their presentations to working like 15 minutes so that we can get everybody in and have time for questions. So I'm going to pass over to Victoria, and I don't know if you have access to your email, but I will send you Benson's biography if I haven't already. So just watch your email for that in about the next 5 seconds.
Brilliant, thanks Chisomo. Shall I bring in Benson first?
If I can get the biography to you immediately, which
I probably have it. Maybe what I should do is ask Judith to speak first, and then we can get ourselves ready.
Sure.
So, hi everybody, it's brilliant to be here. I thought I should say a tiny bit about myself so that you know why I'm here. I run something called the Culture, Health and Wellbeing Alliance in the UK, which is a network for people who work with creativity or with cultural institutions like museums to support health and well-being. We've got about 5,500 members. But until very recently, I lived in South Africa, and I was quite involved with the Medical and Health Humanities Africa network, and was generously hosted by Chisomo in Malawi in 2018. So I'm really grateful to be asked to be a small part of this event, and really want to keep the partnership going between our organisations. I'm keen to learn from everything that you're doing and share that with colleagues in the UK as well. But I just want to say the concept of finding joy in healthcare just feels very visionary at this moment and important, and something that I want to try and share as widely as I can, sort of radically raising our expectations. I really loved what Rubina said earlier about creating a loving and enabling environment. That really resonated with me. In the terminology of public health in the UK, we're talking a lot at the moment about switching from a deficit model to an asset-based model. But I think thinking in terms of joy just takes it to another level entirely, which feels really important. So with that, we're going to hear from 3 brilliant projects, programs, people, groups, and And the first we will hear about is the Lea Toto program for HIV positive households in Nairobi. Then Benson will come in. And then after that, the Voz Harmonia program in Butaro. So I'm going to introduce Judith first, who I think is going to speak, as Chisama said, for about 15 minutes. Judith is the Deputy Chief of Party at the Children of God Relief Institute. She's been overseeing a USAID-funded pediatric HIV care and treatment program since 2020. She's a social worker. She has an MSc in public health, and she's worked for over 18 years in the management of humanitarian, public health, human rights, child and social protection programs, including in Kenya, Somalia, and South Sudan. She's collaborated with government departments, with universities, with international research institutes, with non-profit organizations. Some of her projects include the Safer Cities for Girls program in Kenya and ICT for Health and Development in Somalia and South Sudan. And today she's going to be telling us about the Lea Toto program and its enhanced case management approach and how that's brought joy to HIV positive households in the urban slums of Nairobi in Kenya. Judith, if I could hand over to you.
Yeah, thank you, Victoria.
You're welcome.
Are you able to hear me?
Yes, that's perfect.
Yeah, so I'm going to ask my co-presenter, Joe Fash, who is also on the call, to share my screen. And thank you so much for the wonderful introduction. So, Chisomo, I don't know whether I can give Joe Fash the right to share the screen so that I can be able to set on to my presentation.
Yes, I'm doing that right now.
Yeah, Jofash, could you put it on presentation mode, please? You can go to the slideshow. Yeah, thank you. So as a beginning, Lea Toto program is implemented by the Children of God Relief Institute, which is popularly known as Nyumbani. This is a Swahili word for home. And if you like it, you can also just call it Kogri. Next slide, please. So this is the overview of the story I want to tell you about Lea Toto. And before I proceed, I would just like to acknowledge the founding father, Father D'Agostino, his late, who had the conceptual idea, and together with Sister Mary Owens, who gladly she's on this call, and yeah, and they are the ones who conceptualized the story of Lea Toto. So it's all implemented in the slums of Nairobi, and it's about bringing joy to the HIV positive families. Remember, next slide. Next slide, please. Jofash, if you can move to the next slide. Yes, so Lea Toto, as I mentioned, is implemented by COGRI. It's a community-based program, and it was established in 1998. And it provides services to households that have been affected by HIV in the 8 of the informal settlements of Nairobi. There's Kawangware, Kibera, Kariobangi, Dandora, Zimmerman, Dagoretti, and Mukuru. And as of October 2019, it was serving more than 12,130 orphans and vulnerable children who have been affected in a way or another by HIV. And so some of the services include HIV healthcare and nutrition, psychosocial support, OVC care, and household economic strengthening, among others. Next slide. So what was the problem? So yes, we understand that HIV pandemic does not only affect the quality of life, but it also deprives children and their households of their joy and happiness. And so this was made worse by COVID-19 pandemic, which not only impacted on their health, but also the economic situation, and so was on their safety and also the psychosocial well-being. Because in Kenya, we had this lockdown, students were not going to school, and so many households, especially in the slum areas, actually the caregivers lost their jobs. So as a result, many households could not meet the pressing needs of affording food and even nutrition to their families, school, and even shelter, as well as hospitalization, because within HIV positive households, hospitalization sometimes cannot be avoided. So in the total program, the risk that was at hand was interrupted treatment and also poor HIV suppression, because there was this rumor that if you go to hospital, or you might as well contract COVID-19. So actually, in most of those households, like some of the caregivers were even afraid to bring their children to hospital, or rather for appointments. And that's why the total program, we actually had to focus on our case management approach, just to enhance it so that we can reduce their vulnerability and improve their well-being. Next slide. And so what was our intervention? Let's move on. So I want to tell you something about the case management. First of all, it's a collaborative process, which means like it cannot be done single-handedly. So it aims at improving resilience and well-being of vulnerable individuals as well as groups. So Lea Toto in particular worked with the individual children and also the caregivers, mostly to identify where the problems were, plan with them, and complete a series of actions to meet their healthy, safe, stable, and school needs. So in essence, our enhanced case management approach dwelt on the 4 domains, and it had 7 steps, which were all guided by standard operating procedures, which in short, we call SOPs. So the first step was to identify out of these many children who belong to a household, who are the ones that were eligible to be involved in the enhanced case management approach. And so there was a set criteria, which because of time, I might not be able to detail it now. So once a particular child was identified, and so was the entire household enrolled in this particular program. And so that informs our step number 2, the enrollment of the eligible children, again, following the set standard operating procedures. Once the children were enrolled into the program, we had the assessment, and this is basing on their needs as well as their strengths, because every household, even though they could be vulnerable, but they also have some strengths. So the importance of looking at both their needs as well as their strengths. And so assessment is normally done for the new households that have been enrolled, but we have other households that could be existing in the program where the assessment is done. So once the assessment is done, now that leads us to step number 4, where we do the case plan development or updating, depending on the particular household that we are working with. And so this is based on the identified needs, which have to be prioritized based on what's the pressing need. And in particular, we need to also prioritize the action points. So we also, together with the household, we also look at the roles and responsibilities, who is going to do what, and at what particular time period do we need to have achieved whatever we're planning to do. And also we set indicators that will help us, both the program team as well as the particular household, to be able to determine that now at this point we have been able to achieve. Step number 5 is the provision of the direct services. This is based on the case plans that have been identified. So providing the services that the program is able to provide. But in some scenarios where a particular service is not available, say like a particular household has a child who needs a very intensive medical operation, which you cannot be able to afford, then the program again is at liberty to help this household to identify where they can be able to get this particular service. And so that is what informs the referral of some of the services. Some services say child protection, where we need to collaborate with the government department that maybe looks into child protection matters, then again we refer. Then that leads us to step number 6, where we, other than providing these services and referring for some of the services, we do continuous monitoring based on the case plans that were developed. And so during monitoring, we again reassess the particular households just to see if whatever we set to do, has it been achieved? And if it has not been achieved, then we need to revise the case plan so that we're able to help this particular household, especially through the 4 main domains that I mentioned earlier. And on the flip side, if the particular case plan that was developed has been achieved, that means all the services that they required, all the needs that they had have been met, or this particular household has been supported to be able to take care of their needs, then we celebrate this particular achievement and we support this household to graduate from the program, not meaning that all their needs have been met, but they are at a stable moment where they can be able to self-sustain, but continue receiving some of the main services, and that is particularly HIV treatment, because again, these particular children, at least one of them is HIV positive, and that's why they're in our program. So those are the 7 steps for the enhanced case management approach. I'll move on to the next slide. So for the purpose of this presentation, we looked at some of our intervention between the period of October 2019 and October 2020, and that is the range of the services that we offered. And again, I had mentioned that we are offering based on the 4 main domains: the healthy domain, safe domain, school domain, and stable domain. And under each domain, we have different aspects that we look at. So I'll not dwell on the details of this slide, but just to mention that in some of the age categories and also under different domains, some of the services can be repeated. For instance, when you look at the 10 to 14-year-olds and looking at the safe domain, where we served about 13,742, this means that they were given one service more than once, or maybe different services more than once. And this included maybe life skills, where again, with the COVID pandemic, most of the children were really affected, especially the adolescents and the young adults. So counseling, just giving them the information they require, maybe to stay safe, how to get treatment for maybe the upcoming opportunistic infections, and also any other service. So some of the services actually appear, or rather were given to a particular child more than once, depending on the age. So again, our approach is gives age-appropriate services. So in total, for that period, in our 8 centers, we served 12,130 orphaned and vulnerable children. And again, I mentioned in our 7 steps that once a particular household has met all, like they've gone through the process and they've made all the benchmarks, we have 17 benchmarks that actually we look at and now say this particular household is stable enough to be able to graduate. So out of the 12,130, 506 were graduated. Let's move on to the next slide, please. So what do we learn from our approach? That it considers case by case, that is every child is unique, every household is unique. And also in order to be able to give support, or rather to help them, we need to involve both staff, the community health volunteers, or even the peer mentors at all stages. Then as we do our follow-up, ranging from the identification of the problems through to the serving, we need to not to generalize, but rather to look at through the 4 main domains: healthy, safe, stable, and schooled, so that now this particular client will feel like we have looked at their whole, like their whole being. Again, in our approach, there was a multidisciplinary approach, whereby like it was not just one department serving, but it was like the whole team looking at the different domains and being able to give services and also do regular follow-up. So it all yielded positive and quick changes. Then we had improved adherence, because remember, we are looking at HIV positive households, and that means in that particular household, there's a child who has HIV, or even the caregivers. And so there was adherence, because initially we had been giving treatment, but again, treatment when there are underlying issues, then you couldn't see much in terms of HIV virus, viral loads being suppressed. But now when we give the HIV treatment and also tackling or rather handling the underlying issues, so we could see some improvement. And with some moving from thousands and thousands of copies of the virus to very low detectable viral loads. Next was most adolescents and young people had their self-esteem boosted, because during this time, especially during the COVID period, there was anxiety, there was fear, there was a lot of emotional imbalance among the young people, especially the adolescents and the young people, the young adults. And so through the repeated services, looking at the 4 main domains, we had their self-esteem boosted, and even others were actually motivated to talk to their peers who had high viral loads. So what do we conclude from our approach? That the adoption of the enhanced case management approach is effective in delivery of child-focused and household-centered services, and thereby promoting resilience and well-being of children and households that have been affected by HIV and AIDS. And so at the end, this approach, the enhanced case management approach, leads to happiness and joy among the HIV positive households, since it focuses on the whole being. That is, it looks at the physical, the spiritual, the psychosocial, and the economic well-being of that person. Next slide, please. So what do we recommend? That if programs, especially HIV and AIDS programs, can be able to adopt this particular approach in order to promote resilience, then it will lead to joy and happiness in most of the households. And this approach needs greater partner collaboration, because single-handedly as a one program, you cannot make it. And so you need to reach out to other partners, to the government, to be able to deliver quality services. Next slide, please. And so I would like to acknowledge the particular program where we got this particular story, the LATTO program, which implements an integrated program for both HIV infected and affected children and their households, and our donors, the USAID, and our other collaborators who are the GOK. GOK is the government of Kenya, Manchester International, the Kenya Orphan Aid, and Hot Causes Foundation, among the many other friends of COGRI who've been working with us through this journey of bringing joy to these children. Next slide, please. Yeah, these are the authors, and we are all from COGRI. Next slide. And so these are some of the photos for the program. So we have that's one of our LATTO center in a slum known as Kangemi. We have some of the service healthcare workers in our teams that provide the healthcare aspect to our children. We also have our caregivers. Some of them are very old and elderly, and who are taking care of their grandchildren who are affected by HIV and AIDS. We also do child-friendly psychosocial support. So our counselors actually use child-friendly approaches to reach out to the children. And so, as I mentioned, in the 4 main domains, we also have the school, where we ensure that these children also attend school just like any other child. Next slide. Yeah, and in the first photo, we have our director in a meeting with some of our supporters. That was Manchester International, who also support us with food. And during the COVID period, we also wanted to ensure that the community was safe. So that was a distribution of masks. And these are, in the third photo, we have some of our clients who are waiting to be served in the queue, and these are some of the program beneficiaries together with some of the young people in the program. Next slide, please. Yeah, and thank you for listening to me, for listening to us. And so if you have questions, comments, or anything, this is the moment. Thank you so much.
Thanks so much, Judith. That was brilliant. It was really striking to me how with that huge number of people that you're supporting, you were emphasizing so much collaboration and partnership, and how critical that was for you. I think if our delegates don't mind, I will move straight on to Benson, and then if you could hold on to any questions until the end, we can take a big chunk of questions together, if that's okay, in the interest of time. Thanks again, Judith. And Benson, if you are you there? I'll give you a quick introduction while you get ready. Dr. Benson Mulemi is an associate professor of anthropology. He has a PhD in medical anthropology from the University of Amsterdam in the Netherlands. He's currently an independent researcher based in Nairobi and a visiting prof in the Master of Medical Anthropology program in Gulu University in Uganda. His research interests include hospital ethnography, the ethnography of albinism and livelihood vulnerability of persons with albinism in East Africa, and the ethnographies of health and healthcare in Eastern Africa. Benson and I have worked together before, so it would be very nice to see him again if he's here. Benson, are you with us?
Yeah, thank you very much, Victoria.
Great to see you.
I'm happy to see you again. And I'm glad that the organizers managed to keep me on the program. So I'll take a very short time to say what I had to say in this context. I'm grateful that the discussion is quite encouraging. And I intended to talk to you briefly about our work. I work with my colleagues from Makerere University, University of Oslo, and University of Leeds on a project in maternal healthcare in Western Kenya. So my work here, I'm sorry that I cannot project the PowerPoint just to save time, and also presentation of difficulties doing both from this end because of connection. So I intend to talk to you about the cultural logic of antenatal and perinatal care and its implications for maternal health care in Ahero sub-county in Western Kenya. And this is a project that focuses on healthcare in East Africa. So maybe I should say a few things that leads me to the discussion. I like the theme of the symposium, joy and finding happiness. And I found that the issue of maternal care really has a kind of unspoken ambivalence with regard to this concept of happiness, joy, and hope. These are coexisting in the experience of childbirth. And I thought that I would talk about the striking elements for us could be found in the work of other researchers who have done the same. Adrian Strong, in her work documenting death, maternal mortality, and ethics of care in Tanzania, she had a few excerpts that interested us. At one end, women say pregnancy is not a sickness. In Kiswahili, they say ugonjwa si, ujauzito si ugonjwa. And then they go about to say, no, mimba ni sumu, that pregnancy is poison. And then they say that when you are in labor, the grave is open. So what I'm pointing out that the ambivalence of hope, joy, and happiness in maternal health care is reflected in many African sayings. I remember one of the saying that was picked by one of my colleagues in this project, Professor Shane Doyle from Leeds, when he was quoting the Baganda saying that ukuzala lumbe. Ukuzala lumbe means giving birth is deadly. it is terrible, or it is death, or maybe fatal element. So this shows the long-standing problem of maternal health care and morbidity in East Africa and the rest of Africa as such. In this sense, we are saying that childbirth is associated with the social strain, disruption of social relationships, potentially with a clash between individual and corporate entities or interests. So I wanted to disrupt a bit the discourse on finding joy in healthcare. When I look at the experience of nurses in the facilities that we visited in Western Kenya, happiness in healthcare is two-way. It is both for the caretakers and their patients. But you see, as we say, there is ambiguity in motherhood as a source of profound joy and happiness, which is interrupted by vulnerability and uncertainty, reflected in many proverbs. You see in Kenya, there's a popular Kiswahili saying that when you want to describe somebody who is happy, you say, ana furaha kama mama aliyepata salama. Happy like a mother who was delivered safely. So you can see the ambivalence of joy and sadness. I like in the recent, in the past meditation, the question was, can happiness coexist with the sadness? And I think this is the ambivalence that we have. In fact, I was just wondering sometimes when some people are crying or are laughing, there are tears coming out of their eyes. And when they are very in pain, they also have tears coming out. So what we want to point out is that contrary to what many people in healthcare and health research know, the mere survival of pregnancy and childbirth does not always indicate success for maternal health care. So we have to understand the context of the care trajectories towards institutional interventions, which is important for the expansion of efforts aimed at reduction of maternal injury and debility in order to promote health. So that's the context of our work. As I pointed out, that our work was within the broader maternal mortality in East Africa project, which is being was hosted by the School of History at the University of Leeds, where our principal investigator is affiliated, and this part of the Medical Research Council and Stroke Arts and Humanities Research Council Global Health Project. So for us, we had to do this in Western Kenya, and we aimed at offering a multidisciplinary perspective on maternal health and mortality in East Africa. So our project is a medical humanities project that does not necessarily focus on biomedical factors, but it focuses on human factors which contribute to maternal morbidity and mortality. So we make inference from our work about the human factors that are likely to interrupt even the medical factors with regard to maternal health care and survival of women as such. Yeah, so in this project, we have the interdisciplinary team, Professor Shane Doyle, the principal investigator from the University of Leeds, offering the expertise in medical history. Professor Wenzel Geisler from University of Oslo, providing medical anthropology. Professor Jane Plasto from Theatre for Development from University of Leeds, and myself, and a colleague from Makerere University, Dr. Sauda Namuyalo, who offers the input of linguistics. So in my part, I take the anthropological perspective in eliciting the mother's experiences of healthcare using the usual anthropology methods. So for the sake of time, I want to outline some of the things that we find out that also resonates very well with the theme of this symposium as such. First of all, we find that patients' fears were not freely expressed to the institutional antenatal and perinatal healthcare staff. And this because the backgrounds of the patients were not fully understood comprehensively. And you know, most of the patients return home without answers to their questions. And, you know, women and their families are describing care in various terminologies that also link to other researches that focus on what women and their families need during prenatal, antenatal, and perinatal care. What is coming out very frequently is the fact that they define care as a respect from the perspective of respect. Among the Luo of Western Kenya, they call it Luoro. And this is a perspective where people will derive some hope and joy in a care process that respects them. I mean, we are just literally translates the aspect of respect from the local language. And in this sense, we find that also the dichotomy I'm talking about here, about happiness in healthcare and joy in healthcare being either way, because the nurses would also derive happiness from seeing the patients doing well. And actually, in one of the researches I've done before, sometimes nurses consider themselves as patients because, you know, nurses are always bashed in the sense of inadequate healthcare. But you see, many people do not look at the context of their practice. So most of the health providers we talked to were talking about the experience of generational shift with self-regard to community perspectives on health, the health they give. So they talked about being bashed in the social media and the news, how they are treating the patients wrongly, or how they are very harsh to the patient. But of course, we also want to put this also in the context of the infrastructure of healthcare as such. Then from our study, we find that there is increasing popularity of traditional birth attendants. In our context, they're called Nyamurerwa or Nyamureche, compared to biomedical midwives. And only the biomedical midwives who are popular are those who are not really professionally strictly trained as midwives, but you see these are community birth attendants who combine the medical knowledge and the local knowledge of what good care is. So there's a tendency towards the traditional birth attendants because they seem to be offering what they need, what the patients need. So in this sense, we also trying to look at the concept that fit into understanding how women are likely or unlikely to reach the medical facilities. So there is the issue of trust as part of the cultural logic of care, particularly with regard to responsiveness during labor and childbirth and immediate perinatal health and illness experience. And you see this is actually embedded in maternity care that draw on local understandings of what a good caregiver has. So in this sense, we observed that from our data that available maternity care fits the perspectives on good enough healthcare when it is sustained by confidence, effective communication, perceived integrity, mutual respect, competence, fairness, and confidentiality. I think this has also been found in other studies in traditional settings where people are moving between traditional birth attendants and modern birth attendants as such. In this sense, people who seek healthcare from traditional birth attendants to official medical care are moving between systems of trust. They are trying to maneuver systems of trust, which should be appreciated more, which are appreciated more in the popular and professional and folk sectors of healthcare. I think this is where people have very close relationship with each other. So we have that as an important aspect of thinking about how people derive joy in healthcare. The trust that the patients have between themselves and those caregivers on the basis of those elements that I'm pointing out. And of course, this brings an important aspect with regard to the contradictions that we find when many women talk about the formal health systems, where especially surrounding labor and childbirth. I think there are very many narratives in African settings where women fear being being scolded in labor wards and being sometimes beaten and being quarreled in the as they give birth in that sense. So I think what we're pointing out that what we found in this study is that the aspects that people are looking for have implications for communicating about medicine, health, and healthcare on a global basis. Our argument here is that healthcare programs usually take the so-called medical logic of care, where you are looking at only the elements that define objective healthcare, and objective healthcare has to do with the objective medicine or biomedical provisions as such. So we are arguing that using the cultural logics, we can examine a culture's way of reasoning, which will help us to understand the context of care. And here, it is important to be able to identify, to begin by identifying what defines the cultural logic. And then we have to look at examining the attitudes that surround the cultural logic. What is very important in the cultural logic is that when we analyze the actions that people think violate the logic of care, then we are able to reconstruct ways of approaching their healthcare in a way that satisfies them as such. And we examine the cultural logic of care and institutional care delays. The argument is that, as we saw from the field, the failure by the women and their families to detect, for example, pregnancy, childbirth, and perinatal risks would also define the delay to seek specialized medical care. And this failure may relate to the cultural construction of antenatal and perinatal conditions, such we have local conditions that are defined not as a risk to pregnancy. For example, there is one called Rario in the Luo language of Western Kenya. And people tend to find their own solutions to those kinds of ailments. And probably this could be dangerous to their healthcare. And this, as we found from other studies, the cultural logic of care defines the multiple levels of delay that people experience in the healthcare system. Studying women from the Western Kenya, we resonate with the idea of 3 levels of delay that we can associate with how people construct care. The first delay is the delay to decide whether to go for treatment, and the delay to reach the appropriate treatment institution. And the third delay is the delay to get appropriate treatment. And of course, this also goes with how people define ways of understanding healthcare in their own context as such. And it's defining why, for example, women would have popular comparisons between their experience of modern public hospital and popular sector and traditional birth attendants, whom they are calling in Western Kenya, Nyamrerwa. The ethnographic data in the present study indicate that women anticipate caregivers' kind-heartedness and to be friendly as part of their care values. In fact, they're constructing care as an equivalent of care between kinspeople, which is quite personal, not impersonal, as we find in the practice of modern healthcare or biomedical healthcare. But of course, we are saying that as we look at deviation from the cultural constructions of good care in our biomedical institutions, we are also to contextualize these failings in the wider structure of inadequacies. For example, low understaffing, lack of trained personnel, lack of facilities, and the like. Because my argument is that happiness in healthcare is both for the patient and the caregiver. And the needs of the caregivers in the modern systems may not be taken so seriously, such that nurses, as reported by one of my colleagues in the study, there's a nurse who did not want to be identified when they go home. They would hide their uniform because people are looking at them negatively because of the kind of discourse around their caregiving. So my point is that the happiness is both for the patient and the caregiver, because nurses sometimes call themselves a patient because they have needs to attend to. So,
Vincent, so sorry to interrupt. If you're able to wind up soonish, that would be really helpful.
Yeah,
sorry
thank you
to
very much.
interrupt you. Thank you.
Yeah, all right. So I would want to use that background, probably with what we have and what we find in many health systems in Africa, to make some winding remarks. One is that there is a preference for the type of care provided by traditional birth attendants during home care deliveries over the care provided by nurses at the health facilities. And this can be a social barrier to maternity health care because participants are choosing between the former institutions and the traditional institutions because of the attention that they're getting from them. So in this sense, we're saying that the demand for biomedical services can potentially be created by providing women, their families, and their communities culturally contextual knowledge that does not devalue local beliefs and practices by reducing the financial, geographical, and social and gender barriers to seeking health services. And of course, the point is that not all those constructions of antenatal and prenatal healthcare are negative, because we are encouraging researchers to look at how to blend the preferences in the popular sector and the preferences in the biomedical sector so that you can meet the healthcare needs of the mothers. Thank you very much, Victoria, for
Thank you,
the time.